So, thank you for the opportunity of being here again in person to talk about the diagnosis and management of PMI. So these are my disclosures, but my biggest disclosure is that I'm a big fan not only of soccer, but also of biomarkers, and I really believe that the biomarkers are there to help us to make better diagnosis and treatment of our patients, and between them troponin. And that's my dog. Its name is Troponin, and I know that when it gets elevated, it's very dangerous, and mainly if you have food. So
Ultra-sensitive troponina, the dog, or all troponina?
Troponina. No, we call it tropo, because you have to be fast, otherwise you don't eat. And the same thing goes from elevated troponin after non-cardiac surgery. So the problem is there's more than 3 million surgeries being performed worldwide, and the mortality related to these surgeries is still higher than expected. The PMI, the perioperative myocardial infarction or injury, is a big contributor to this mortality, and we know it's related to high rates of short-term and long-term mortality. So the goal would be to promptly diagnose a PMI and treat it to reduce this mortality. And for this, I would like to start with an example. There's a very normal case with an old lady, 82 years old, who in the weekend fell and broke her femur. So she came to the hospital. She had already a history of a coronary artery disease with a previous PCI. She was asymptomatic, and she was operated. The preoperative troponin was normal. Then she was referred to the ward. Everything was fine. And the first day after surgery, no troponin was obtained there. And then in the first hours of the second day, she went into cardiac arrest, pulseless electric activity followed by a ventricular fibrillation. She was reanimated, and when the ROSC comes, she had a troponin over 700. Then she was taken to the cath lab. There was occlusion of a marginal artery that was performed a PCI, but unfortunately she died. And when we order a troponin in the blood that was collected the day before, we can see that this value was already by 100. So she had a PMI. So that's the first red flag on the diagnosis of a PMI. There's just no symptoms. More than 80% of patients with a PMI don't have any symptoms, and that is becoming more common the more sensitivity of the troponin assays. And then we search for a second tool as cardiologists, an ECG, and you can stop searching because there's no ischemia signs in this ECG, because only 25% of patients have any kind of ischemia in ECG. Therefore, it's essential to do screening with troponin to find these patients. The second red flag is that up to 50% of these patients being operated will have a baseline level of troponin above the 99th percentile. So we have some kind of chronic myocardial injury. So it's mandatory to have a baseline value in order to differentiate the chronic myocardial injury for the acute injury that happens with surgery. And how exactly to diagnose PMI? So in the basal PMI study, there were patients included at high cardiac risk submitted to non-cardiac surgery, and the screening was performed with a troponin before surgery and in the first and in the second day after surgery. And if there was a delta here of 14, why 14? Because that's the 99% of this assay, that's high sensitivity troponin T, then you would say this patient had a PMI, and he would become automatically a consultation with a cardiologist. Later on, this was validated for another assays, in this case for high sensitivity troponin E from Abbott, with this logic that a PMI requires the doubling of the 99th percentile of the respective assay. And we got exactly the same results. The occurrence of a PMI is related to worse prognosis, short and long term, up to 1 year. But now that we diagnose the PMI, how to treat it? So there's very little evidence about how to treat a PMI. At this point, we're doing some individual approach and multidisciplinary discussion. And why is that? It's because the PMI is a troponin elevation. And in order to treat it, we have to find out the cause and to treat the cause. And what's the cause of a PMI? Here we try to determine and adjudicate why is this troponin elevated. And we can see that that could be, for instance, for extracardiac causes, and that means not that there's a false positive and the troponin is not coming from the heart, but that the main disease is outside the heart. The classic example would be a sepsis with a secondary myocardial injury, or a pulmonary embolism, or the trauma in thoracic surgeries. And this is only about 13%. Most cases, 85%, we call it, there is a cardiac PMI, and that could be a type 1 or a type 2 MI, or could be other cardiac problems like acute heart failure or arrhythmias, namely atrial fibrillation. That's why there's only retrospective studies that try to describe how they treat the PMI, and there's only 2 studies who try to prove that some strategy works. The first of it, the authors did some propensity match scoring and compared patients that receive what they call intensification of clinical treatment, and that is the optimal treatment with aspirin, beta blockers, statins, and ACE inhibitors. And patients who received that, they had less MACE than patients who did not receive that. The second one is the only randomized trial in this area, the managed trial, in which the authors included patients with myocardial injury after non-cardiac surgery with an ischemic cause and randomized them for the bigatran versus placebo. And in this case, patients with the bigatran, they had less of a combined endpoint for myocardial infarction, but also from venous and arterial vascular issues. So what's the problem is that it's an heterogeneous disease. So to treat it, we have to treat the cause. That's the flow chart that we follow at this point to our patients with a PMI. So first, you establish the diagnosis that, again, is based only in the delta of troponin. No additional criteria is required for the diagnosis. And then we make basic clinical examinations with ECG and hemoglobin, and we look if this patient had, of course, an ST elevation MI or ST depressions with typical chest pain or suggestive of a type 1 MI. We treat them accordingly. If not, we search if there is an extra cardiac cause like a sepsis or a pulmonary embolism and treat this cause. If not, we search for acute heart failure or atrial fibrillation. If not, we check the hemoglobin, and if there's severe anemia or bleeding, we correct that. And for all other patients, remains unclear myocardial injury, likely a type 2 myocardial infarction. We give these patients statins, and then if they have no known coronary artery disease, we search for coronary artery disease. If they have non-coronary artery disease, we search for ischemia, and we do an improvement of the clinical treatment. And that's what we do nowadays based on the evidence we have. So, I think it's not working. Can you play the next, please? So we could conclude now that there is two basic commandments of the PMI. The diagnosis is challenging, so I'd say know what you're looking for if you want to find it, and do the screening in patients at risk. And after diagnosis, know what you're treating, because then you're treating it properly. So it's essential to do a good clinical differential diagnosis to find the cause and treat the cause. And with this, I would like to thank all the PMI team and all the people that make possible this research and dedicate their life, part of their lives, or whole their lives sometimes, to help this field that needs help. And at least, I'm not done, please, this last is the most important one, is that a message for Salvatore and the Italian team that the international team has been preparing for years for the soccer match, so they should watch out. Thank you.
We will have many Brazilians in our soccer team this year. Okay, short discussion. Questions? If you can introduce yourself.
I'm Dr. Hyun-Suk Yang from South Korea. Nice to see you. It was a long journey yesterday for me. I arrived here yesterday very, very late.
You didn't come with the metro from Seoul to here?
No, much. The flight. And thank you for the wonderful lecture. And I really agree, perioperative myocardial infarction or PMI diagnosis is challenging. But we should think about the definition of a PMI, perioperative myocardial infarction is also challenging too. So some people just have a definition of increase of troponin, but some people are not completely agree about that. Because myocardial infarction is such a demand and supply impairment or some myocardial perfusion damage. We are always think about myocardial perfusion damage. So if it is not cardiac PMI, I think mostly sepsis. It is not the traditional definition of a myocardial infarction or myocardial perfusion defect. So we should think about the definition of a PMI first, and then we are searching for the diagnostic challenge of PMI. This is my comment.
Thank you. You were absolutely right. The definition of PMI is extremely challenging. What we tried to do is to make something that is easily applicable in clinical practice, because there is other definitions that was also used, like elevated troponin after surgery. But then again, we don't know how it was before. So if you use that, we are including patients with chronic myocardial injury. But I think the main point is to give something that the clinician understands and can use, because if there is a definition, there has 4 lines of definition. A myocardial infarction is something in a patient that don't have a sepsis, that don't have a lung embolism, that doesn't have a trauma, that doesn't have, then nobody will memorize that. So we're trying to create, and we receive a lot of calls because troponin is high. What do I do? Okay, but that's like a severe sepsis. You do nothing, you just treat the sepsis. But do I need to give anticoagulants? No, you just need to treat the sepsis. So the idea was to create something easily applicable for the guy that is there at the front.
Thank you. Another question? Okay. Thank you very much.